Phacoemulsification is a widely performed surgery with successful outcomes, but sometimes we may face difficulty even in the easiest step. The main function of haptics is to provide proper positional stability to avoid the tilt and decentration of the IOL. Usually, the IOL implant after injecting opens gracefully in the capsular bag, but there are few instances where the haptic doesn't open up nicely. The present video is about one such incident and its management. I have no financial interest to disclose. My patient is a 63 years old male having a cataract of grade 2 nuclear sclerosis in his right eye with a best corrected visual acuity of 6/18. His other eye is pseudophakic with a best corrected visual acuity of 6/6. Both eye fundus were within normal limits and the patient had no systemic illness. So, right eye phacoemulsification with IOL implantation was planned. It was a routine cataract surgery with capsular axis under the red glow, followed by cortical cleavage hydrodissection. Nuclear management was done by the direct chop technique and nuclear pieces were emulsified at the supracapsular plane. Cortex removal was done with a bimanual irrigation aspiration cannula. Capsular bag was inflated with viscoelastic and single piece foldable intraocular lens was implanted. It was being noticed that both the haptics are stuck to the optic. One of the haptics was gently nudged with the eye cannula and with few strokes it opened up. But then it was revealed that the haptic has opened up to gain an S-separate configuration. To my surprise, the second haptic was stuck on the other side of the IOL, so it had to be flipped to release this haptic, which was done partially with the eye cannula. Viscoelastic was injected. And then with a dialer, the rest of the flipping was done to orient the IOL in the Z-shepherd orientation. Meanwhile, the other haptic has twisted within the bag and it was released by gently nudging with the dialer. So ultimately, the IOL was placed within the capsular bag in the correct Z-shepherd orientation. While looking back, I could think of the following reasons for this challenge. Insufficient amount of viscoelastic in the injector cartridge while loading. So the IOL must be lubricated with viscoelastic in order to slide smoothly from cartridge to the bag. Second can be loading the IOL into the cartridge much earlier than it should be. So to conclude, in every case we should ensure that the IOL haptics have fully opened up in the correct Z-sepid orientation, and sticky haptics can be released either with the IA cannula or in some cases with the dialer. Thank you.